We'll get started as soon as Frank's got the,
In the body.
is that all set, Frank?
Yes.
Okay.
You gotta mute your audio.
Larry's in the waiting room.
So we could start with introductions, even though we pretty much know each other, but it probably wouldn't hurt. And there's one person that we pretty much know, but maybe she'd like to hear who some of the newer members are. So why don't we start with you, Ann?
I'm Jana Thibodeau. I'm the Quality Assurance and Improvement Chair. And I'm here to present on the incident review.
I'm Howard Reed. I guess this is my second meeting as an appointed member, so glad to be here.
No more. Okay.
Hi, I'm Anna Tamus. I'm still in waiting to be approved.
Tomorrow.
I'm a psychologist in the community. Nice to meet you.
Jessica Connor, member of the CSB and mental health subcommittee.
Augusta Klein, member of the board.
Stu Burke, member of the board and substance subcommittee.
Jan Lynch, member.
Sheila McHenry, member and member of the GD subcommittee.
Lynn McConnell, Janae, member of the Developmental Disabilities Subcommittee.
I'm Mary Hutchins. I'm a member of the board and a member of the mental health subcommittee.
I'm Frank Rupert. I'm the commissioner.
Harmony.
Hi, I'm Harmony Ayers Friedlander, the Deputy Commissioner.
Becky?
I'm Khaki Wunderlich, still being patient also.
Thank you.
I don't think she's.
Larry?
I'm Larry Roberts. I'm a member of the board and the chair of the mental health subcommittee.
Everybody?
Yes.
Oh, okay.
Jan is on there for a presentation.
Yeah, I saw that face, but not the name. So next, that we do have an addition to the agenda, and that is an executive session at the end, so we can discuss an applicant that Mary put forward. Are there any other additions or deletions? Okay. So approval of the minutes from January 2024 is next. Do we have a motion to approve? Okay, any discussion? There's a first from Stu and a second from Mary. And do we have any discussion? The only thing I noticed was that it's fellow Ross Milne. Wouldn't that be a public health fellow?
Yes.
So just an addition of those words to
Is
make it
that-
clear. That's like way here, right here,
Second page.
Yeah.
On the back.
on the back, like the third paragraph from the bottom, I think, about approximately. It starts with Commissioner's Report / update.
Okay. Oh, public health. Yep.
Okay. So all in favor of approving the minutes as presented?
Aye.
Great. Next is,
Sorry, did you have a mover and a seconder?
I'm sorry.
Who moved it?
I moved it and Mary second.
Thank you. Just for Karan until she gets up here. I gotta take notes.
Yeah. Okay, so next is privilege of the floor. Are there any questions or comments from the board? We don't have any guests other than Janice, so anybody else have anything? All right. Then we'll move on to board correspondence or announcements, which I don't have any. Someone else has some, which I take it there are not. So the first item of business is the Deputy Commissioner's report and update, and that would be Harmony.
So I really don't have much of a report to give. I think there's something on the agenda later about Markham House, so I can speak to that now. Markham House is a community residence in our county. It's run by Lakeview, and unfortunately, This is a familiar story we're hearing with different residential programs in particular. They have had some significant struggles in staffing. So in the past, they've reduced the number of people that could live in the program. This is the highest level of service in our community. The community residence design is 24/7 support. Everybody has their own room, but they share like a kitchen area, living room area, and that sort of thing. So it's a pretty significant program in our community. And unfortunately, they've had to temporarily suspend services. They knew as early as November that this was a possibility and did reach out, and they were hoping that they were going to be able to hire enough staff that they would be able to not have to temporarily suspend the program. But in December, they had to start to move residents. Now, OMH has been very involved in this process and has had meetings with me and with Rich Shaw, who's our SPO coordinator, every 2 weeks during this transitional process to make sure there was good oversight by the state in terms of residents getting moved to other locations, making sure all their appointments and their providers' needs that they were being met. And so forth. So currently there's one resident left at the community residence. There have been some attempts to find another location that to date have not been successful. So they are continuing to staff the program with staff from some of their other locations. They have settings in Ontario and Seneca and Wayne County as well. So they're pulling staff from quite a distance to be able to do this. So hopefully that individual will find a good location soon. All of the people have been moved to other locations within our county. One person actually preferred another location outside the county near their relatives. So they were able to accommodate that. And the person says they do not want to return. They're very happy in this new location. So these meetings are continuing with Office of Mental Health, reviewing how everything's going with the residents that have transitioned, and also reviewing a workforce plan. The hope is really to get the service back up and running as soon as possible.
I guess we could hold discussion of questions until the item on the agenda so that we can, we don't keep Hannah any longer than we have to, in case she wants to get home. But thank you, Harmony. Okay, so the next item is.
There you go, that, Jan, just a couple of other updates for the group. Wanted to let you know that the second care team with the city of Ithaca is in the process of launching. So we identified one of our social workers that was interested in jumping over to that role. It's gonna be a little bit different than the way the sheriff is. Correct me if I'm wrong, Harmony. She's gonna be stationed at IPD and they will come grab her as needed. Because they don't have someone to assign the way the sheriff's department did. And because the city is smaller geographically, they felt that it would be more effective for them for whatever officer needed that support to be able to come grab. There will be work on making sure folks are trained and on the officer side and all of that. So we've got two different models working, and we'll get a chance to see how both of them go. But we're excited that that's very close to being operational. I don't know that it's actually started yet, Harmony.
Well, since I've been out, I'm not 100%, but today may have been the first day. So we're pretty close.
And then just two other real quick things on request for proposals. The request for proposals for the opioid settlement funds that came to the community service board is out, advertised now. And we're thankful that we were able to partner with the city of Ithaca. So the funds that they're receiving were coupled in to that. So it's a joint RFP that will be coming through the county. The MOU is signed between the city and the county. And so we're just waiting for the RFP to close. And then the RFP for the outreach worker program If you'll remember, there's a long-standing outreach worker program on the Commons and in the city of Ithaca. Then Harmony was able to work with Family and Children's to get a grant for the rural parts of the county. We're bringing those two together. The grant ran out and the legislature has stepped in with funding behind it. So we have once again partnered with the city of Ithaca and the Downtown Ithaca Alliance to bring that pool of funds together. So it'll be one program with 4 outreach workers, 2 essentially in the downtown area and 2 for the rural parts of the county, but it will be one program, expecting that all 4 people could work in any of the places. That RFP has been reviewed by the 3 entities and is now with county finance and the county attorney, and we're hoping within a couple of weeks there'll be approval on that. And then the RFP will get posted as well. So a lot of movement on those projects starting to happen, and hopefully we'll be getting those programs up and operational with new partners relatively soon.
That's great. I didn't mean to not have you have a space.
Okay. Harmony probably should have taken credit for all that anyway, because you're the main one to make all those MOUs and RFPs get done with Ross's help.
What is there prohibiting? Like the like opioid settlement funds, like go to pay additional salaries at the housing places to like add on to the salary that's already being paid to workers there?
It's a good question. I'm not sure that it necessarily is prohibited. We'd have to look at what the settlement funds can be used on, but those pools are pretty broad. I think one of the challenges is not long-term recurring funding.
Right.
And I think generally speaking, the expectation was to see new programming come out of the opioid settlement funds. And, you know, I think both the county and the work of the subcommittees, these were the projects that were identified for funding, so.
Okay, thank you.
I would also add that you're not allowed to use this funding for a program that already exists. There was a lot of concern, you know, that people would just shift programs they were already funding to those dollars, so it has to be a new service.
A service is temporarily suspended, restarted, does that make it a new?
Oh, you're talking about a community residence that treats people through OMH.
Yes.
So that's like I thought you were talking about the opioid dollars to be used for it. So that's a kind of a different pot of money. And OMH.
Harmony, I think that is what she was asking, was could the opioid settlement?
Oh,
On to
yeah. Actually, OMH is very concerned about workforce shortage, so that does bring up another point. I'm sorry, I totally derailed the meeting, Janet.
That's okay.
They've created a new position, a workforce coordinator across the state who's putting a plan together. She should have it together in a few weeks, and she would love to come out and meet with our board virtually and learn from you about workforce shortages. And I think OMH is looking at rates of pay in some of these programs already, because these are their state licensed programs. So they have to make sure that the way they're being reimbursed, you know, covers all the costs and that people are getting paid a salary that makes sense to them to do this very difficult work. So I think OMH is really focusing some energies in that area as well. But yeah, you couldn't take those dollars for a program that already exists.
Just thought I'd ask.
Creative thinking. Anything else, Harmony or Frank? Okay, then we can move on to the annual incident review.
So hi, my name is Jenna Thibodeau, and for those of you who were here last year, this will be a bit similar, but I'm just going to review the activities of our incident review committee and our corrective actions and our response. So on the left-hand side is our membership. So Susan Spicer, who's the clinic director, and myself are the co-chairs. And then we have representation ranging from all the different parts of the organization, including our medical director and social workers from both pros and the clinic. That in 2023, the Incident Review Committee reviewed 37 reportable incidents. And then this compares, on the right-hand side is 2022, and on the left-hand side is 2023. So in 2023, there were 19 deaths, 11 were attributed to natural causes unrelated to mental health diagnoses. 7 were fatal overdoses, and there was 1 suicide. There were 15 suicide attempts, 5 from personal injury and 10 from non-fatal overdoses, and 3 from other incidents, including violent crimes and medication error. As this compares to 2022, there were far more overdoses and more deaths. So the committee discussed hypotheses of why that could be. And it ranged from, there was more polysubstance drug use in the toxicology reports from the overdoses. That maybe people are more engaged, and so then there's more reportable incidents because we know about the incidents happening. And then also potentially from the aftermath of COVID that there are fewer social supports and people are struggling more. And then also I would ask all of you and now or at the end of the presentation if you have ideas why. I think that we are wondering that also.
Jenna, can I ask a quick clarifying question? Remind me, is this the data for everyone all the patients who are associated with Tompkins County Mental Health?
Yes.
Thank you.
Versus
anyone seen at CMC for?
no,
That's
just
what I thought.
sending medical clients who are
Okay.
active.
Thank you.
This is not county data. This is just
Yes.
Department
the
data.
the people who are affiliated with.
Correct.
Yes.
So you all are technically, you are our advisory board as the clinic as well as serving as the community services board. You, just like Family and Children's has an advisory board, there is a requirement of us to present this to our advisory board annually. So in this moment, you are serving as the advisory board to the mental health clinic in this building, and this data is specific to that work.
It's also notable that if someone overdoses, but it's not an explicit suicide attempt, it's not a reportable incident. So there are other overdoses which are not represented in this data. So there are even more overdoses that were non-fatal that are not listed here.
Are these only adults?
Do you track, could I ask a question? Do you track those overdoses that aren't reported, but do you keep a record or
Not
anything?
in the same way. So we have to report to OMH and they have a NIMERS portal where we have to like submit it to the state and then also provide documentation of how we followed up. So we don't do that for non-reportable incidents.
Can you give an example of like a non-reportable incident?
An overdose that was unintended.
Like an accidental overdose?
Yeah. Is an example. Things that happen to people when they are like if someone is injured or hurt at home, that would not be a reportable incident. If someone has an injury in the building, I believe that would be. But it's mostly violent crimes and suicide and overdoses are the most common reportable incidents.
Intentional overdoses.
Yes.
Okay.
Yeah.
Another just point of clarification, are the suicide attempts only those who ended up at the emergency department, or anytime a patient reports to a therapist, I had a suicide attempt, it gets marked in? So-
Reports to a therapist. Yeah, but it gets really tricky because in the hospital discharge summary, sometimes people will say, I don't really know why I did. Like I took a whole bottle of Tylenol, but I just wanted to see what would happen. And so that's very ambiguous about whether or not there's intention to commit suicide or not.
Do you have the data divided by age?
We don't, but we could. That makes sense. There are so few cases, you can really kind of parse it by hand for any information you're looking for. But to answer your previous question, there are children. We have children clients, and if there's a reportable incident, they would be included.
Mm-hmm.
More questions?
With fentanyl and everything,
how do you distinguish between an accidental overdose and as I've heard here, a purposeful overdose? Isn't a purposeful overdose a suicide?
So if the person dies, it's reportable. If the person doesn't die, then we would assume they can report on their intention after the fact. If that makes sense. So we go by the client, what they say. So of the discussions that the incident review committee had, this is basically a synopsis of the corrective actions that we discussed. So addressing co-occurring substance use disorders is at the top of the list. Providing staff training, emphasis on risk assessments and safety planning, caseload management and engagement, addressing client social determinants of health, collaborating with law enforcement and the development of the care teams, staff recruitment and retention, and updating policies and procedures. I wanted to introduce, this is based on the ACE inventory. So it's adverse childhood experiences. So basically it's an inventory that looks at childhood trauma. And there's a lot of research and evidence that shows the relationship between trauma and adverse health effects and death later in life. So while the corrective actions that we have are more specific to the cases, as an organization, I believe that we are addressing some of the things at the bottom of this pyramid to help address trauma and to look at racial and social conditions and social determinants. And I just wanted to make the relationship clear of how the incident review committee is looking sort of at the top of this pyramid, but the organization, I think, has really tried to prioritize and focus some of the root causes at the bottom. So here are the mental health program priorities. So integrated care for mental health and substance use, addressing them concurrently, trauma-informed care, diversity, equity, inclusion, and belonging, and suicide prevention. So I've also sort of like threaded some of the activities that we've been doing to address these 4 goals as they relate to the incidents. So in 2019, we became an opioid overdose prevention program, or an OOPP. And then in 2021, we were recertified. So that means that we can get naloxone or Narcan kits directly to our organization without having to ask for them from another organization. And it also means that we can distribute them to clients for free. So the developments that happened in 2023, that we started to distribute the kits with fentanyl and xylazine test strips. That we updated our policy to include a role for the front desk staff in naloxone distribution. Kits are now available for clinicians in the mailrooms. So they used to be locked in the nursing room, and it started as like you had to have a prescription for them. And now it's gone to give them out as much as you can, give people 4 at a time. So we've just made them more readily available for clinicians to distribute. We put up signs to advertise that the kits are available. And then we also created a brochure. Yeah.
Do you have numbers on how many kits are being given out?
We do. And I am not responsible for reporting to OMH. And the person that is, do not get back to me. But I want to know, and I will tell you.
Once you get it, that would be great.
Yeah, but I do know that we have distributed, the estimate is 3 to 6 times more in 2023 from 2022.
Love it.
So we've had a lot of push to make the kits available, and to make clinicians know that they can give them out liberally. And I think that's been very successful.
Great.
We've even talked about putting, I don't know what it's called, like a metal thing in the bathroom where people can access them. But then I think there was some discussion about how if there are clients who are hoarders, that might not.
For the clinicians who are at the OMH satellite clinics in the schools,
Yeah,
can the clinicians give them out to the student clients?
there's no, right? Yeah, because they're a prescription, correct?
There are school policies against drugs, prescription type drugs. Kids can't carry aspirin over the counter, so there are rules there are rules against it in the schools, which is part of the Melissa project. Jessica trying to figure that out.
Yeah, I know.
This is not an end around
Just looking for my loopholes.
Yeah. Technically, we could hand it to them in the space, but as soon as they walked out of the space, they would be in violation.
Yeah. Okay.
Stu has a question back here.
Yeah, they advertise it on TV now, where public service announcements have a whole thing about fentanyl and contact this number and you get it for free in the mail.
Mhm.
They have the small version of it.
You can get them free at pharmacies as well too.
Yeah, okay.
Standing order from Dr. McDonald for naloxone now. The challenge with schools is they're a different setting and state ed sets the rules, not DOH.
Gotcha.
I think the important thing for kids is that they know where to go and where they can tell other people to go to get both the testing strips and the naloxone. Yeah, that's what's really important. Which these beautiful brochures can help with. Okay.
We're
So,
actually working to try to change this at the state level. There's conversation going on to try to address it in schools, but schools are a tough nut to crack. And we're doing everything from trying to figure out, can we set up broader school-based clinics to be able to do things, but it's in New York, state ed runs schools, DOH runs health, and neither of the two shall ever mix. So it's a bit more challenging to navigate that. And the problem is that I don't think anyone disagrees about naloxone, but as I said, kids can't carry aspirin in the school, right? And it's an over-the-counter medication, so it's a bit more complicated.
They're giving out naloxone, but the strips, I don't see where that's readily available.
I believe they're in a pack with the naloxone kit. So we started getting those.
Okay, so
from
that's.
the state as well. Yeah. And then this is just front of the brochure, but the back lists all the organizations in the community that provide kits for free. But sorry, Harmony.
I just would add, yeah, we have actually two brochures. So we also have a brochure that talks about how to use the strips. So each kit has naloxone in it, and it also has xylazine and fentanyl test strips in it with a brochure that explains that. And one of the other nice things about the brochure is that it includes a number you can call so that you don't use a loan. And how that works is you call the number and then somebody stays on the line with you while you use. And if you don't continue to talk to them, they'll send emergency help to you because they will think something bad has happened to you. So all of that information is chock full in these two brochures.
So these are substance use assessments. The month is the month that the client was admitted. Purple means that they got a substance use assessment. Blue means that they did not. And green means that they were younger than 12. So we don't assess unless it is clinically indicated for children 12 or younger. So this has improved since I have been in the organization. And we will continue to improve as well.
Anna,
Yeah.
are those the total number of clients admitted to the outpatient clinic each month?
I will say roughly yes. It should be. Okay, yeah.
Thank you.
So one of the priorities for the organization is trauma-informed care. And then the incident review committee really took a close look at risk assessments this year, I would say. And so the trauma-informed care committee met quarterly in 2023. CCSI did a training series between May and September. And Dina Bodner from DSS also facilitated a 5-part trauma-informed care training series. Then after that, we conducted a organizational assessment, which was a follow-up to one that we did in 2022. For risk assessments, the clinic director initiated a client focus group. So she takes every client whose birthday is in that month and then looks at the charts to see if their assessments have been updated and what's missing. That we implemented an IRC utilization review. So we have a utilization review specialist who works in the QAI department, and she started looking at anybody who had an incident. She looks at their chart and does utilization review for across the board to see what's missing or and then we sort of jointly followed up with a clinician and we're like, hey, can you update this person's safety plan the next time you see them? Or just, we made an effort to follow up and make sure that, that people were alerted if there were things missing in the chart. We provide monthly caseload data to clinicians, including the most recent assessment dates. And then of the clients on people's caseloads who are on the high risk list, they get weekly data. So that will have whether or not the person has SSRS, the date, whether or not they have a substance use assessment, whether or not they have a safety plan, and whether or not they have a violence risk assessment, their last date seen, how many days since they were seen, and whether or not they have a next scheduled appointment. So clinicians get that email the night before they, or the evening before they have their high risk treatment team. And I think I'm going to skip, I think I messed up my slides. So this is that process. So they receive the email update. And then they have the meeting the next day where they have the clinical director and the psychiatrist and then also supervisors. And then they jointly discuss this is going on with this high risk client and people add suggestions and discuss scheduling medical appointments and medications, etc. So these are some of the trauma-informed care initiatives that are underway in 2024. So hopefully you will hear more about them next year at my presentation. But PROS has hired their first peer specialist. I believe they have 2 and they're looking to expand the program. The clinic was selected to participate in a statewide peer learning collaborative. So that basically is a planning process for how to onboard peers and plan your program. There's a trauma-informed care committee selected representative artwork for the building, so it's a more welcoming space. There is a trauma-informed care policy, which is in its draft form. That the trauma-informed care committee identified a PTSD assessment tool and a corresponding staff training, which I believe is comprehensive and a bit of an undertaking to implement. And then the PROS director is developing a group trauma treatment. So those are some of the initiatives that that are happening now. As far as caseload management, so caseload management is relevant to client engagement because if people are managing the acuity of their caseload and the size of it, it helps them to make sure that they're staying in touch with people and engaging. So supervisors met with the clinic director, the fiscal administrator, and QAI monthly to evaluate caseload composition, workflows, and time management. And then the mental health clinic schedules quarterly no client days where clinicians participate in trainings and catch up on client engagement and documentation. So before those no client days, clinicians also get a packet of their caseload data so that they know, and it's organized by task sort of, so that they know who's the person on their caseload who they haven't seen in over 90 days, and then who's on the high risk list and what are the outstanding assessments or paperwork they need to do.
Can I ask a quick question about the last slide? What are the average caseloads?
It varies. So I actually tried to include that data and it is different from month to month. So there was like the August snapshot and the December snapshot were pretty different, so I didn't include it. But off the top of my head, the difference between like August and December for social workers, I think was 87 to 105 for a social worker. For nurses, I believe it was 130 something to 150. For doctors, it was between 460 and 670. And for interns, I believe it was about 20.
Okay, entrance 20. For those, is there any pullout for the child and adolescent folks?
We sometimes do look at that separately. And that everybody has different goals depending on, some clinicians work 35 hours a week and some work 40. And so we have different goals depending on, and also the forensics department, sometimes they're a crisis.
Sure.
And so it varies, like we adjust it accordingly.
Great, thank you.
And also for children, we know that they need to be seen more frequently. So that's built into their schedules for those clinicians.
So is there a specific cap for those clinicians? Is there a specific caseload cap for those clinicians to account for that, or just it's generally built in.
I'm not sure how they build it in, but they know that children need to be seen more often. Just as a general rule of thumb, they need to be seen more often, so their caseload is considered smaller. But I can't tell you the specifics on how they do that.
Thank you. And do we have data on how, like by data by patient regarding how frequently people are being seen and for active patients and how many sessions they're being seen for during an active engagement period?
Yes, we do have that data. We also have a levels of care form that we developed, which looks at there's how often the client is actually seen, or how often they're scheduled for, but then there's also what the clinician believes
Right,
they
it should be.
need.
Yeah.
And sometimes there's a bit of a gap between those two things.
Yeah.
So we have a level of care form, which it's interesting. Clinicians don't have to fill it out, and they do. So I think they find it really useful. And that is it a medication management patient or is it a new person?
Yeah.
How often do they need to be seen? Do they have medication needs? And so that provides information. I think we developed it in the beginning of COVID where we weren't sure if clinicians were going to be out and if someone needed to take on someone else's
Right.
caseload, that it would be the essential information that they
Right.
needed. But it's been a useful form and it has really valuable data moving forward also.
Awesome.
Yep. So I believe in 2022, we reinitiated open access. So those are open access hours. We also have an easy referral form. Clients don't have to have it, but they can bring it. The value of it is it tells us where they came from. So if they're referred by their PCP or they're referred by somebody, it's a way for us to know who referred them. And then this year we introduced a screening process for court mandated clients. It's a 12-question screener, which assesses for if the client is interested and interested in care and if they're there willingly, because it's voluntary. And I think the idea is that it gives the client agency and it empowers them in their therapy services versus feeling like they have to come because the court said so. That as far as other engagement efforts, we have engagement letters, which are embedded in our EMR. That was an initiative that was led by clinicians, and they said it would save us a lot of time, it would be really helpful if there were form letters that we could choose, but it has a field where they can include a personalized message. But then QAI and the front desk staff work together to print out the letters and mail them out every week. They're also given caseload lists to help them figure out who needs an engagement letter. So there's 30, 60, 90 pending discharge and discharge letters. And then we also developed a PCP referral form so that we can exchange information with PCPs. If, for example, somebody is stepping down, so they're not very high, they're medication management and they're sort of ready to graduate from TCMH and their PCP is going to take over their prescriptions, that we can give them a referral letter or form that has their information to help the doctor prescribe those meds and continue their care. We participate in an OMH Psyches project, which is a quality improvement project, and they used our engagement letters as a gold standard and presented them to the other clinics in the state. That we, as part of the Psyches project, we integrated SDOH screeners as part of our intake process. And then if people have a positive screen, so if they indicate that they have a need, that they are linked with resources and referrals. And one of those resources is the community health workers who are at public health. So we created an internal referral process so the person can be linked with another person to help them navigate the health system and or social service system in our community. And then we also offer telehealth per client preference. So this year we were required to start to document for whether or not it was phone or Zoom. Or in person. And so we also had a client satisfaction survey. So this is just a preliminary response. The survey was just sent out this month. So we don't have all of our responses yet. But I thought this was really interesting. That for almost 39% of our clients want a hybrid. They want to sometimes have the option to do Zoom or the option to have a telephone call, but they also want to come in person. And then I believe that 36% of people want to come in person. And I forget that I can't see my notes. So that I think it was like 10 and 15% want Zoom and telephone. So I just thought that was interesting as far as client preference. And then another important part of engaging high-risk clients is helping them to access outpatient services after they're discharged from the hospital, from the BSU. So we have a point person who tracks discharge summaries. That's valuable because there's really important information in the hospital discharge, both for the psychiatrist and also for the clinician to know why the person was hospitalized and what meds they were discharged on. And so sometimes in the past, there's been a big lag, which has come up in the incident review committee as an issue where the doctor doesn't know that the person was discharged from the hospital or why they were there or what meds they were on. So now we have a point person who follows up again and then again if they don't get it. And that's been working. We have a nurse who attends hospital treatment team meetings. And then we coordinate long-acting injectable medications, which we have an increased number of patients who have LAIs now. And then there's also an OMH and DOH statewide initiative looking specifically at this issue. So they're trying to facilitate a conversation and coordinate hospitals and community services. And I believe they released guidance for hospitals about this.
Yeah.
I think this is awesome. Is there a way in the future to also create a parallel process for active clients who are seen in the emergency department and undergo a mental health evaluation, but don't end up being admitted because there are similar metrics in terms of expectations in mental health follow-ups after being seen in the emergency department, even if not admitted?
Is it possible? Yes. Are we doing it now?
There may be.
Considered for the future.
Yes, I think we have a Rio list, so we got hospital alerts, and those don't discern between an emergency visit and a BSU admission. So if somebody goes to the emergency room, we are notified, and oftentimes that is discussed in the high risk meeting.
Awesome.
So the clinician will at least be aware, and it would probably come up, I bet, in a session about why they were admitted.
Great, thank you.
Yep. How many do you want to?
Oh, just that, and I think when we're looking at some of these RFPs and some of the services that people in the programming might be able to provide, that may be an area of focus. It may also become an area of focus for the Office of Mental Health, and they have discussed wanting to design a program where people get like intensive supports at the point of discharge or the ED from hospitals so that they can better make connections in their community, because some of that really has to happen out in the community, not just us scheduling an appointment with a person. It's like, how do we now actually get the person there? So it's definitely an area we need to find better solutions for. So I think that may be other agencies involved in that process. It's a big need.
So this year we also successfully, I believe there was an RFP, and we implemented an on-site pharmacy called Genoa Pharmacy that they specialize in SMI populations. They offer multilingual services and resources so they can get their medication description and directions in like hundreds of languages. They especially pill packing for clients, and they negotiate prior authorizations. So this is beneficial in a lot of ways. It helps for clients who we had several overdoses, which were from prescription medications. So it helps with reportable incidents in that way. I imagine it helps with engagement, because if you can pick your prescription up in the same building that you're getting your care. And it also helps with that, or medication assisted treatment. Because there was a long discussion about initiating buprenorphine in our clinic, and there was a obstacle of not being able to get to the medication fast enough. Like, who was going to believe and go to the pharmacy and wait for it and then bring it back? So having it on site facilitates that as well.
Anna?
Yes.
Don't kick me out. For Genoa, is there any tracking of medication outages, like them not having the medication on site? I'm just thinking, like, locally and nationally, we're running into ADHD medication shortages. So I'm wondering how, if Genoa is running into similar things, or if I can start having people just go to Genoa because
maybe they keep better stock of ADHD medicines.
They are a different entity from us,
Yeah.
so I'm not sure, but we can follow up on that.
Thank you.
Yeah, or I can connect you to the point person there.
Thank you.
Yeah. So as Frank stole my thunder, just kidding. That this year there was the development of the Crisis Alternative Response and Engagement, or CARE team. So the Tompkins County Sheriff Department partnered to create a co-response team, which responds to mental health crises in the community, and the Ithaca Police Department was launched maybe today, but in 2024. And some of the goals of this program were to divert individuals in crisis from criminal justice system, to avoid unnecessary hospitalizations whenever possible, to de-escalate crisis situations, to link people in need with community treatment and support services, and provide in-person follow-up support within the first 24 to 48 hours after crisis. And then Harmony showed me today that they have this amazing dashboard. So there's a link for it in the presentation. And there are 3 different tabs. So there's demographics, responses, and outcomes. So this is just the responses tab, but I was really impressed with this. So this is the data from today as far as the CARE team incidents that they've responded to.
This is just the sheriff's department.
Okay.
It's the sheriff's department website and it's their data that they're posting.
And this is from when it started.
Correct.
to now.
Yep. Staff recruitment and retention. In 2022, we began a certified National Health Service Corps loan repayment site. So we currently have 6 staff members who are participating in that, 5 of whom are social workers and 1 is a nurse practitioner. And then we also have worked to add new direct service positions. So in 2022, we were able to expand the civil service job description to licensed clinical therapists, which includes a lot more licensure types than previously. And then there's a 1-year civil service exam waiver called hiring for emergency limited placement or help for hard to fill positions in New York State, which means that social workers don't have to take the civil service exam if they're hired this year, which is, I think, a big obstacle for some people. There were 5 new clinical positions in 2023. 1 was a licensed clinical therapist for adults. 2 were school-based or for kids, and then 2 were the CARE team staff, which are, what's it called? OTR, they're over
target requests.
And then in 2023, we also successfully hired and onboarded 6 new clinicians, which I think shows there's a lot behind that, finding 6 people, hiring them, and training them. For diversity, equity, inclusion, and belonging, Heather facilitated a book read. This book is Anti-Racist by Tiffany Jewell and Aurelia Durand. The entire organization completed the National Class Standard Training, which is a cultural sensitivity training developed by the Health and Human Services. Dr. Jarrell Enzel was a consultant for Whole Health and provided trainings on September 19th and 26th. And we asked because we care. There was a training series with Julia Ressler, who's the manager of community health and engagement, and Herb Alexander, who's the chief diversity equity officer at Cuba Health. And they came on October 24th and November 7th. And then there's for suicide prevention, we have a zero suicide committee who met quarterly. We had a staff training on zero suicide in February and a deaths of despair training in March. Senior leadership presented at Suicide Prevention Town Hall in September, and we completed a Tompkins County Whole House Zero Suicide Implementation Assessment in August. And then our policies and procedures are always under construction. But we updated our high risk policy to include coverage for high risk clients when clinicians have unanticipated absences for more than 2 weeks. We updated our long acting injectable policy to include the 4 R's of healthcare. So the right patient, right drug, right dose, right route, right time. The emergency response policies are in development in coordination with the county health and safety coordinator and the director of emergency response. The naloxone distribution policy, that clinicians have increased access to kits, as well as the front desk staff now have a role in distributing them. We are working on a transfer policy where clients will be notified when they're assigned a new clinician. So they used to find out if their clinician went on maternity leave or left or retired, but they weren't necessarily introduced to their new clinician as a way to engage them and say, hey, guess what? I'm so excited to meet with you. So we are updating that. And then our discharge policy, we are updating. So if somebody goes to a nursing home or rehab for 30 days or more, that they will be discharged and then they're invited to return through rapid re-engagement, which means they don't have to go through the entire intake process. And that is to, if somebody goes to rehab for way more than 30 days and then they hang out on someone's caseload and then there's an incident, it's sort of to help to button that up. And that, I believe, is the end of my presentation.
Thank you. That was great.
Yeah.
Very comprehensive. Are there any questions or comments?
Point is, so you were able to get sufficiently detailed information about the 7 fatal overdoses to really be able to identify the involvement of fentanyl or something similar?
Yes.
In all or most of those?
Yes, so we do a special investigation for most of those, which means we do a FOIL request for the police report, and then we interview all the clinicians and or community service providers who are also involved in the person's care, and we do like a in-depth chart review. And then one of the people on the committee who's a special investigator will write up a synopsis and then bring it back to the committee and present that. So we sort of do like a root cause analysis of a deeper root cause analysis of what we could have done better, if anything, as an organization to help that client.
But you do have information of the actions.
Larry.
Information.
Yeah, so we get a death report from public health, and then the toxicology reports for several of them had polysubstance use, including xylazine, which I thought was new for sure.
Does Larry have a question?
Yeah, so I have a couple things I wanted to say. First, to just say thank you so much for how well organized all of this is. I feel like we've always had a really good report process for this, but I feel like in the last couple of years, we've really stepped up our game in terms of what we know about what's been happening in the clinic. So I really appreciate that. I have a couple of questions for Frank. One is, I know that this is just the data for the clinic and for the programs in the department, but I'm also aware that we have a larger sort of mission to sort of have a sense of what's happening in the community at large. Do you have a sense of how other agencies are doing, or could you get a sense of how other agencies are doing in terms of incident review and policy changes? Just so we know, like, that there aren't huge outliers in terms of mistakes that are happening, and that entities are really engaged in the process in the same way that we tend to be. And thirdly, I really think that this care team is the latest in a long line of our attempts and the attempts by law enforcement to better engage. And I'm really happy with it. And I feel like it would be important to reach out to the media to really explain how completely and how thoroughly Tompkins County has an emergency response for people who are in crisis, and that we're working closely with the police department and the sheriffs, just to dispel this idea that somehow there's a problem with that relationship. So I don't know. I don't know what to suggest in terms of a media strategy, but I feel like we need to tell that story and tell it really well, because we do such good work. And the police, I've always felt like the police in Ithaca and Tompkins County do a really excellent job responding to people in crisis. And I feel like we wanna tell that story.
Yeah, I can work backwards on those, Larry. I think we have done some media outreach when the sheriff care team launched. The sheriff has also put together a video that got a lot of traction, a lot of media attention about the program. I think IPD launching will be another opportunity. We need to let them get some time under their belt and get some positive experiences that we'll be able to share. But I know we're going to want to do that with the city as well. And I agree that we do need to, we need to help build back up the perception of law enforcement in our community as, you know, as is appropriate based on our relationship with them. On the other question, I don't know the answer. We can certainly ask Family and Children's, you know, kind of what their approach to this is. It's the incident review is required as part of licensure, so OMH should be, you know, reviewing that when they come to audit them as well. What I can tell you is we do have an opioid data project going on right now with one of the public health fellows, where we're hoping to be able to create a dashboard of sorts to give more information about what's going on related to overdoses. The challenge that we faced is we always have been going down this path of trying to get raw data that we can somehow share with MOUs and agreements, and then having one party be responsible for aggregating it so it's non-identifiable. But I think we're shifting past now, and rather than figuring out how to share raw data, we're asking our partners that have that data to aggregate it themselves and provide to us data in a form that they could publicly display it if they wanted to, and they still can, but we want to bring it all together in one place. So that's the path we're on now. And we have a fellow that's working on it, and I'm hopeful that by summertime, we'll be in a place where we'll have something where that information is more readily available. It's very difficult because there's a part of the community that wants real-time data, like the minute an overdose happens, where it is, and that's very difficult for us to do for a myriad of reasons. But I think from a strategy and a planning perspective, we can certainly get more recent data than what we get from the state, which now is a couple of years old. So we're trying to move that up closer so we can use the data for making decisions around strategy and planning more effectively. So lots of work going on around all of this.
Thanks.
Frank, along those lines, since Family and Children's Services has a new clinic director, it might be helpful to invite her to a meeting as well.
Fair idea.
I also reached out to Family and Children's recently and talked with Alicia. Well, it's easy now because it's Alicia, the executive director, and Alicia, the new clinic director. So you don't even have to remember more than one name. But we talked about having meetings because we're both the same licensed kind of service to get together and talk about some of the new changes and regulations. How can we better understand each other's work and be supportive of each other? We're the only two entities that are like that, and really make sure that we have that close communication relationship. So I think finding out how they do some of their things and meeting with Alicia, their clinic or even their executive director would be a great thing to learn more about what they do, because I know that they're trying just as hard as we are to reach the significant needs in our community.
Who has a question?
Yeah, I too enjoyed the presentation, a lot of facts, good numbers, a lot of questions that colleague has raised that I'm like, I want to ask that too. Okay, go ahead. You got the floor. But the big picture, just to point out, is how many clients does mental health cover? Right.
2,000.
Okay, so 2,000, and Family and Children, we don't have data on that.
They print out their newsletter. Oh, I looked at it semi recently.
So how many are there? I don't know.
It's roughly 800.
800.
Yeah,
Okay.
that's about
And you have roughly 120 therapists in private practice. Where do those stats fall under? I don't think we're getting that.
That's the hardest part to get.
Yeah.
We also have Ithaca College and Cornell that are
Right.
counseling centers, so there's a lot of different data points. I think each of us as an organization or as an individual clinician is serving a different is serving a niche population to a degree. And I think we have the most direct connection with family and children because we're both Article 31s. But for example, they don't do any of the injectable medications. They have an MOU with us because we specialize in that. It would be hard for them to have the staff to be able to do the numbers that they see. So we just do them all here. And same with the colleges, right? They're primarily doing students, but they're only doing it to a certain degree, and then it exceeds their capabilities. And so the students need to find other things in the community. So there is a good bit of crossover. I don't think we have a true picture of the total number of people served in the community. And to your point, there's folks that have hung their shingles and are practicing as individual practitioners, that it would be nearly impossible for us to know the total piece of it. I will say this, and there's nothing we can do about it today, tomorrow, even next year. The people that know this, that know these numbers, are the people that pay for it. The insurance companies, Medicaid. Getting the information out of those folks would change our world as far as being able to know what's going on. But we can't get that information. We can't even get it effectively from Medicaid, which the state pays for. So getting it from the third party insurers is nearly impossible.
I think one piece that I've read, can't remember exactly where, but as you point out, who's paying for it, how many people are being seen by a mental health professional in this city, or is it county? I think it's 25% are under the care of a mental health provider, according to the insurance people.
Oh,
I wouldn't be surprised.
In 2022, the Family and Children's number was 1,289.
Oh, okay.
So one of the first slides that you showed the significant increase in suicide. Did we see that again? Sure. So that raw data,
No, yeah.
do you have that in percentages? Because I'm wondering if you are seeing more clients this year, given the increase in clinicians that you have, and if there's different.
Our census data is pretty similar to the year previous.
Okay, so the same number of patients are being seen year over year. So that big jump
Is real. Yeah.
Can we see that again?
Yes.
any further questions?
I'm not sure.
Yeah, I mean, what was it, 33 this past year? Were the total number of cases?
37.
37.
I need you to add me again, sorry.
Sorry.
No, I hopped off.
Can I ask a question?
Of course.
Is there information on how long people have to wait to get seen? That is, people who are referred and so on.
Yes. It's improved a lot. So with open access, I don't want to quote number of days, but it's gone from, we had to close intakes at some point for a month because we were down clinicians and the wait time was not realistic. And now I believe it's under 2 weeks for somebody to be seen, and the wait time between first and second intake is also we closed that up. I want to say it's like 9 days. And then the time from, so they see their primary clinician for the second intake, and then they're admitted after that. And so the time from referral to admit has also gotten a lot, has improved quite a bit. And then at that high risk meeting, there's also an intake meeting where on that Friday, so people who are hospital discharges, for example, sometimes the psychiatrist will schedule with them before they're even admitted. So if they know they have a long-acting injectable, or they know that they're familiar with a client and they're going to be a rapid readmit, that the psychiatrists and the medical staff will sort of triage who needs to be seen, who's the highest acuity and who needs to be scheduled right away. So there's a pretty robust system or process in place for that.
Yeah, our time for intakes has a direct reflection to the number of staff.
Yeah, sure.
We've seen it. I mean, we were under a week pre-COVID. We had worked really hard to try to get to a good place, and then COVID, and then things got really bad at the end of 2022, which is, I think, when we closed partially closed intakes, and then we had a mass loss of staff during 2023. The help thing came along, which allowed us to get rid of the exam, and then all of a sudden, we were able to fill positions as well as our interns. We're now able to effectively hire our interns on, which we weren't able to do before. So that's been a huge boon for us. So hopefully those numbers are going to continue to come down. And please remember that our philosophy has been get them into intake quickly so we can triage, right? And so there may be somebody that comes to intake that it takes longer to get in, but at least we've given them, they've had an opportunity to be evaluated for crisis and how acute their need is. So that has always been our model, is let's get them in quickly for the first visit to see who they are, what they might need, even though it may be longer before they get to that second visit or get assigned to somebody, versus saying, no, we're not going to take intakes because we're going to make sure everybody gets, 5 days to their next appointment or whatever it might be. So that's been our philosophy, and that's not everybody does it that way.
We will point out that the mental health clinic has been doing that. The numbers, the wait time gone up and down, and it seems like it's back down. The substance use agencies, as far as I can see, are at kind of record highs of waiting lists. That was something that the community pressed on them, and they did a good job to get it down. The triaging they've been utilizing. They went from, with COVID, as long as a month be seen. And, obviously that's not a good situation. That, far as my understanding, is still in flux.
Okay, well, we should probably move on. Did you have one more thing?
I just wanted to know, what is the open access? How can you just describe that quickly?
Oh, yeah, sorry. They don't need an appointment, so they just walk in and
Okay,
it's
so
first
it's
come,
walk-in.
first served. Yep.
Okay.
And
During
then
those hours.
Yep, so when I first got here, we had a small grant, and that was, we had open access, which I believe OMH endorses. And then people really push for scheduling. They think that they want an appointment. So we sort of drifted back to that. And then during COVID, we started scheduling, and our intake times, the wait time just kind of got longer and longer and longer because people make an appointment and then don't come. And people are worried that if they take their kid out of school and come and wait for an appointment, that they won't get seen. But in actuality, they do. And then if there are situations where someone is taking a kid out of school, I believe we do schedule them on like a per case basis. But the open access, I think, has, with a lot of trial and error, has really demonstrated itself to be the most effective.
Yeah, we get complaints about open access. We get complaints from primary care providers about open access when they said, what do you mean you can't give them an appointment? They can't come at 9 o'clock and sit there all day and wait. Okay, but you're not giving them an appointment for a month and a half. But
That's right.
yes, sorry. But it, as Jana has said, it does. We have a difficult no-show rate. Our no-show rate hovers between 30 and 35% for appointments. If you apply that to appointments for intake, we are in a lot of trouble. It would push way out on folks. So the inconvenience of potentially having to wait an hour or two here on a day that you come in when we're busy, it significantly increases our ability to get people in and reduce time from when you're interested in getting in to actually getting in. So we've done both, and the appointment just doesn't work with our client base. We try to be flexible with folks if there's a particular need for it, but the open access has been the most successful in us getting people in and getting them in quickly.
And in practice, if people come at like 4:30, that I believe Melissa, our intake person, she'll still do the paperwork with them and try to get their records and get them started and get the ball rolling. Like, even if they come not during the right hours, I think that we really do try to move stuff so that they get seen as soon as possible.
Speaking for PEDS primary care providers, we are pro open access.
Yay!
It has been really, really wonderful and
Good.
working really well.
So excited. But this means that they see a different clinician when they come, or just
The first time.
The intake is always
just the first,
in person.
right? But okay,
So the first, they do like an assessment.
okay.
So they get their, everything from like their residency to their financial stuff to like just a few assessments. And I think that helps them know who to assign them to. And then their second one
It's
is
like the primary.
yeah, and then they do substance use assessment and like the more in-depth things with their primary. Yeah.
This has all been really interesting. Thank you so much, and lots of information that people wanted. I do want to move on because we had this kicked off the agenda one other time when it was on. And it's the subcommittee membership discussion. And Mary's going to do that because she's chair of the nominating committee, but also on the nominating committee is Stu and myself. And we just want to clarify a few things or get opinions on a few things having to do with membership. So I'll let Mary take it from there.
Hey, I wrote down a few notes to remind myself of the points I want to cover. So as Jan said, we're revisiting an issue that we've gone back and forth on, and we want to revisit it again. The issue is whether contracted agencies can be official members of the CSB or the subcommittees. A few years ago, we decided that it was appropriate for them to be members of the subcommittees, but not the CSB. And at that time, our thinking was twofold. That as a member of the subcommittee, there was not a conflict of interest since subcommittees are advisory and they don't directly vote or endorse funding decisions. At that point, the county attorney supported this distinction. On the other hand, he recommended that those on the CSB not be contracted agency representatives. And the second point at the time was that we were having difficulty filling the subcommittee slots. And we felt that the representatives from the different agencies would be good potential members. So we didn't want to cut off that group. Since that time, a couple of situations have come up that have led us to question this plan. And I can give you an example to kind of play out how it became an issue for us. We had a candidate for one of the subcommittees who was directly from an agency that was receiving funding. The program she represented was getting direct funding from the LGU. And one of the references that she gave was from another agency that was receiving funding. So when I called that reference, they said, we didn't know we could be on the subcommittee. We wanted to be part of the subcommittee too. So it raised concerns for us. Regardless of the fact that they don't necessarily have a lot of influence, there's the perception that they do. And that's one of the factors that people are, the way they think about this, that we have found. We're concerned about subcommittees turning into a provider group and that other groups are not adequately represented on subcommittees. So we're interested in your feedback about that. We've also talked about the idea of should funded agencies be required to participate on subcommittees without that official status of being a member. So that's another thing that we can talk about. So those are the issues that we're finding, and we haven't taken any action on that particular candidate at this time, but want to check in. So does that, I know Frank, you've had some thoughts about.
Yeah, no, so the county has a very liberal conflict. Maybe it's conservative. We'll go liberal because we like that. Our county is much more liberal, right, John? So Jonathan, who was the previous county's attorney, opinion was they could technically serve on the community services board, but if there was a vote that came before the board that where a potential conflict exists, they would have to recuse themselves. The county, so the county has it's a very fine, like, it has to be a direct conflict kind of perspective. I am of the opinion that if it appears to be a conflict, it's a conflict, even if it isn't, right? I mean, that's how I was always trained on these issues. So I'm probably more conservative when it comes to this particular idea. The conflict aside, the biggest issue you're going to be faced is what Mary just talked about. They're particularly on the substance use subcommittee. I imagine all of those entities would want to have a seat on that committee, and we've heard that from them in the past. And you're going to be faced with a couple of problems. Either you'll end up having an agency subcommittee, or you're going to have to pick and choose which ones you put on there. Right, and I don't think either one of those are situations that are, that will be super comfortable. So it has been my recommendation, since you all have been talking about this, that the subcommittees also be excluded, but have them come as part of their contract requirements, right? And we can build that into the contract, and then it gives them the opportunity to be there, to be a part of it. But it also allows us to bring in voices outside of the system, right? Because I think that's in large part what you all are voices outside of the system, meaning those of us that work in those direct service organizations that can give us perspective, different perspective on how we can serve folks in our community. So that's kind of just been my place. It's really up to you all. And I don't think it's going to be the end of the world, regardless of what you decide to do. It just may create some uncomfortable situations for you.
I think that the agency motivation can come from a mandate, but right now in the substance use subcommittee, which off and on been a member for 30 years, and the agencies want to be there to see and hear what the feedback is in the community. So they're self-motivated to come and participate. And they know that they can't be a voting member, but they definitely have a voice and influence on the decisions that are made in the committee. And it has been a little top-heavy with just the agency representatives coming into, which is part of the reason why we have a bit of a vacuum on the committee with members of the board. I'm the only member of the board that's on the committee, and we're down a couple of other members on the community at large portion.
Yeah, that's something that we would just want to highlight too. The openings that are, except for one, the other openings on the substance use subcommittee are reserved for CSB members. So we're making a bit of a plea to all of you who may not have an assignment at this point, that's really where our need is right now.
Yeah, definitely. And I personally think it would be important to have anyone who's on the board have to serve on a subcommittee at least for like 2 years or something, or a year even, just to help that. But that's not the point we're discussing right now. And I did want to mention too, that besides the appearance of a conflict, we've had some discussions. This is quite a few years ago now, but we've had some discussions where they've ended up being issues that really kind of gave an agency some extra knowledge that would help them to be able to provide what was being talked about. So it's not always as clear cut as we're coming straight into it saying, this person from this agency has to be out of the picture for this discussion, because we're not, if we're discussing something, we're not necessarily at an end point yet. We're just discussing it. So that's just something I wanted to throw in.
Okay.
Kathy?
Just on the historical pieces, just so that everything's sort of out there. When we made the decision not to allow contracted agency people to be on the CSB, it was for exactly what you're talking about, Mary, that we were hearing some of that. Well, wait a minute, why is somebody from this agency on there and I want to be also? And that felt like it was not going to serve the CSB. I don't personally agree with it. I kind of like Frank's new idea But the state does agree with Jonathan Wood. And when I talked to the attorney for OMH, I can't think of what his name was, but the guy that came and did a presentation for us. His position was, well, they can just recuse themselves. But the problem is you only recuse yourself really for a vote or something. It doesn't stop you from being in the conversation, impacting the conversation. And as
And influencing
perhaps
others.
getting information that gives you, a leg up against other agencies. But I like what Frank was saying, sort of getting them there, but maybe not letting them be members. As long
I
as we
like that idea as well.
Yeah. Jessica, if we removed the people who are under contracts, are we in a position in any of the subcommittees to be so lacking in members that it would cause difficulties with functioning at this point?
The chair on the DD subcommittee is from Unity House. It's a co-chair situation. So one is from my agency, which isn't funded by anything that comes through here, and which is Flick. And then the other co-chair is from Unity House. So that would, then they're doing a great job.
They're very good.
Yeah.
I'm
Excellent.
I'm pro everyone having the insider information and being at the conversation. So I think I would be really in support of making it part of the contract, that contracted folks should attend subcommittee meetings and
every meeting is public.
Right.
And they're being zoomed, right? So the subcommittees are all zoomed. We're not broadcasting them via YouTube because it's a bit of a thing to get onto YouTube. But these meetings are public too. So they're all public meetings as far as anyone could attend and hear the information that's being discussed. There's a difference between sitting in the audience and hearing and being part of the conversation, which I think is some of what you're grappling with too.
And the subcommittees can be voting on different issues via Zoom, whereas we can't do that here. So
they're completely zipped out.
You don't have to come out in the winter.
We don't vote on that much on subcommittees, though, right? It's mostly just approving the minutes.
Yeah.
I think
The idea is to forward to the board.
Right, to recommend different things.
Once a year, we have that, brainstorming, and these are.
the local services plan is where I would say they have the most influence, if you want to say, because we do ask the subcommittees to do the legwork and then bring it to you all for kind of final review and approval.
Right.
So just a point of clarification, if someone from an agency came as just not as a member, just as not even a guest, just that, they're interested, they cannot participate in the conversation?
Well, it's really up to the chair to determine, but generally speaking, the members are there and there's invited guests that can give presentations and such. But when you're talking about something you might be making a decision on, it usually you hear from people and then you talk amongst yourself and make your decision as a board or a committee.
Larry?
I'm mute.
Larry?
Yeah, so I was just gonna say that, just to the point of the conversation, I think anybody can participate in conversations at the subcommittee level. That certainly happens in the mental health subcommittee. So I hope we come to a final decision about this, because
We've been talking about it a while. Does anybody else have an idea or a thought that they'd like to share?
Well, just so I understand this correctly, on the committee I'm, on, it doesn't seem to be an issue. But I'm just wondering, the substance use committee has come up. Are we lacking members precisely because agencies cannot be?
No, because the CSB board members aren't
Oh, okay,
volunteering to
okay,
be
so
on
that's-
it. We
to me,
have to
that's
have 3 on each
A different
subcommittee.
issue.
Yes,
Yeah,
yeah.
yeah.
Well, we have 3 openings on the substance use committee, and 1 is a community member and 2 are CSB
Okay.
openings.
Okay.
And everything else, we'll talk later about the final opening on the CSB, but the other two subcommittees are full.
Yeah, and we're approaching the end of the meeting, so if you have anything else to say.
I'm just wondering how we make this final decision. Is it by consensus, or where do we go with?
Is there?
So,
I mean, is
so-
there a vote? Do we want to vote? Do we want to?
So right now we have the board, you can't be, and the subcommittees you can. But on my subcommittee, there isn't anybody who's like that. They come, agencies, the directors, the subdirectors, even counselors have come as guests, as they're called. So it's not an issue, but if somebody wanted to come in, we have the rule now that says they can. So do we want to change that is the proposal.
Well,
And then just one question that I had is, do we have the authority to exclude people with contract affiliation?
from the subcommittee, yes.
Clear that that's something that we, given these, it sounds like there've been some conflicting legal responses regarding this. So it would be, if we were going to do that, it would be important to be clear.
Yeah.
We in fact can do it.
Ultimately, what we need to do is update the bylaws.
Right?
Right, I mean,
100%.
that's the standing thing, and the bylaws are what set the rules for the committees. You all draft them and then the legislature approves them. So you do have the authority to do that, but ultimately the legislature is the group that is appointing these folks. So they could choose to say, no, you can't put this in your bylaws if they wanted to. I don't think they would. They usually don't. Bylaws usually go through. So as long as they concurred, yes, you would have the authority to do it.
Okay, so,
I just note one thing that might help Howard is that there's nothing in the state law or the county charter that says anything more than that the subcommittees have to exist and they have to have 3 CSB members. So there's nothing that precludes us from doing that, although Frank is right, it ought to be part of our bylaws.
The bylaws need some improving anyway. So
We paused them
Pause
because
that.
the legislature is making that decision about term limits that they.
Yeah.
Right.
and let's just,
We're probably back to, we should look at the bylaws again, and this could be a trigger. I think they're good. And I think this is actually in there. So we would just have to adjust it however you guys decide to adjust it, and then we can move those forward.
I think what's important tonight is that we kind of try to get to a decision, because this has been kind of hanging over everybody's head for, well, at least the nominating committee's
Yeah.
heads for a while. And we still have one more thing to go, and it's 7, so I hope people can stay. It's just a short thing where Mary wants to introduce or speak about someone who's applied. But first, we need to know where people stand on, do we want the subcommittee to include people who are representatives of contracted agencies? Or would we prefer that they not be on the subcommittee, but attend the meeting, which can be a separate thing that they have to attend the meeting?
Yeah, we could put it in the bylaws that they have to attend the meeting. And
We
that they
could put it in
can't.
their contracts is what we have
Contract.
to do.
Yeah, it wouldn't be in the bylaws.
Just be careful on that one, because you got to decide what would happen if they don't. And be
Exactly.
comfortable with that before you put it in the contract.
Okay, so I think that we should grandfather in anyone who's on them now, but I think we should not have contract agencies be on the subcommittee. I'm just gonna throw that out there to get this started. So you can disagree with me, you're welcome to.
And I like the part about including in the contract some representation from those agencies as part of this.
Well, or at least strongly advising that. It's not clear. You can really require it. I mean,
Okay, so what do other people think?
I support Jan's position.
Great, thank you. Not for supporting me, but just for putting your opinion out there too.
I'll second that if that's what you were meaning to do. So I guess we're calling for a vote then.
Okay. Did anyone else want to say anything or before we move on? I don't want to cut anybody off.
Well, if they have an opportunity, if people from contracted agencies still have an opportunity to attend, then I'm fine with that.
And speak at the, they can speak at the meeting.
Encourage them.
Yeah.
Okay.
Yeah.
Yeah, we want them.
Yes.
They have an important contribution.
We need them.
Okay.
But as Frank said, the appearance of it, we vote once a year for something important, but even that once a year. I agree with Larry. It should be an open meeting. People should come and speak.
So we have a first and a second if we're voting. And so.
Could you state exactly what it is we're voting on?
The suggestion is that, well, the motion is that, contracted agencies that contract through the county would not have representatives on the subcommittees. They would not be members, but they should and could attend the subcommittee meetings. Okay, can we go ahead with the vote? All in favor? You're not, okay. All right, well, it looks like we're pretty much in agreement on that.
I will pull out the bylaws and make sure this language is reflected in there and then bring those forward to you all for next steps.
Great, and the grandfathering in of people like the DD subcommittee chair, who's doing a great job for, I mean, that's not the only reason, but just to be fair, because he came in at a time when there were different rules we were following.
Is that grandfathered as long as he wants to be on it, or grandfathered for the rest of his current term?
What?
You say
What was the
grandfathered,
question?
but grandfather for the rest of his term, or can he just keep renewing that under a grandfather provision?
Yes, there are two ways you could understand grandfather.
What do you suggest, Frank? You have probably more experience.
Let me write up some language and I'm gonna send it by you too, Kaki, because you drafted the bylaws the last go around, so we can finalize that and then you guys can decide.
Okay.
I'll also check with the county attorney on what their thoughts on it are.
Then,
I
yeah,
think they have to be reappointed by the legislature, so grandfathering them beyond their existing term, I think would be challenging. Just from a fairness perspective. But I will check on that and we'll have a recommendation for when you look at it in the bylaws.
He is a terrific.
thank you. Thanks, everybody. And Mary, would you like to go ahead with the executive session? We need to make a motion.
Pretty quick.
We go into executive session.
Great. Sue and Jessica.
Hey, Jan, before we go into executive session, can I just ask something quickly? I sent a note to Frank and to Harmony about an incident that occurred at the rescue mission or whatever, St. John's Community Services at the shelter. Can we talk about that incident at the next CSB meeting?
Sure.
Okay,
Thank you.
Just give me 1 second.
we had a first and a second for going into executive session.